Again, I do want to thank you all for joining us. My name is Diana Arias with the Community Technical Assistance Center at NYU's McSilver Institute. And again, I would like to welcome you to today's offering, Treating Family Conflict and Coercion, an overview with Dr. David Kolko. Dr. Kolko is a professor of psychiatry, psychology, pediatrics, and clinical and translational science at the University of Pittsburgh School of Medicine. He is also the director of the Special Services Unit at UPMC, Western Psychiatric Hospital, a program devoted to the development and dissemination and implementation of evidence-based practice for children or adolescents served in diverse community settings or systems, including the juvenile justice, child welfare, pediatric primary care, and mental health. Additionally, Dr. Kolko serves as adjunct staff in the section of behavioral health at Children's Hospital of Pittsburgh. He is also the co-developer of Alternatives for Families, a cognitive behavioral therapy, also known as AFCBT, an intervention for family conflict and coercion. In this role, he is also involved in the dissemination, evaluation, and refinement of this intervention across the U.S. as well as internationally. So once again, thank you all for joining us. Thank you for your participation. And now I'm going to pass it along to Dr. Kolko to get us started.
Thank you, Diane. I appreciate that. Hi, everyone. And by the way, let me also say thank you to Vanessa and Kara for making this event possible, and also to you for joining today. I hope this is going to be something that benefits you clinically. I welcome your feedback. We're going to do our best to try to take questions at various times and answer them as best as I can. I also wanted to just say I hope you're having a nice Valentine's Day. So with that, I think I'm just going to go and say a little bit about our agenda. I'm going to say a little bit about the characteristics of family conflict and coercion, a little bit based on the research literature. We're actually going to do an assessment or talk about assessment, and then we'll actually take a break. And then we'll come back and talk a little bit about AFCBT, but I think what I've tried to do is pull materials that are relevant for pretty much any type of family, whether you're using AFCBT or not, and then we'll take any final Q&A towards the end. So let me just say a little bit about what the literature says about family conflict and coercion. I think the first thing I should probably say is I was kind of disappointed when I went and looked for this information because there's not a lot really on it. And I think one reason for that is that we really don't have good definitions for these things, what someone calls conflict or what they call coercion. So I've tried to pull some information from recent sources. And this is a slide that says something about family conflict. And much of this information is probably known to you. But it's always helpful to kind of start from kind of the same place. And I wanted to just highlight a couple of features. One is we can appreciate that family conflict takes a lot of forms. You know, verbally is how we kind of think of a lot of it, but also we have physical forms of conflict, financial forms of conflict, or psychological conflict. So it really could be quite a diverse term. The rates as you see on this slide, are actually fairly modest. So it really tells us that this is something which is common for a lot of families in the United States. What about the risk factors? You know, here are a few that we've identified in the literature. One is poor communication. We'll say a little bit about that today. Having unhealthy expectations of others, you know, experiencing stressors, and we'll say a little bit about that as well. And then poor emotion regulation, the inability to manage, let's say, the reactions to those stressors. There are many effects of family conflict, and here are a few just broadly. There are a whole set of physical problems that people experience when they're exposed to family conflict. And as you all know, there are many mental health effects. You know, we have things like internalizing problems like anxiety, depression, externalizing problems like aggression and oppositionalism, and drug use. So there are clinical reasons to be concerned about families who are in conflict. What about coercion? Probably a term even less clearly appreciated in the literature. I am going to focus on forms of coercion between kids and their caregivers. So, coercion in that regard speaks to patterns that reinforce, that actually build in negative parent child interactions. And so many parents find themselves kind of frustrated that the strategies they've used have created patterns that are unwanted and very troublesome, and oftentimes may result in, significant clinical problems like fighting or arguing or things along those lines. As was true for conflict, coercion is pretty typical for a lot of families, quite common. Now, obviously, if you work in mental health settings, this may be far more common, but these are just general rates in the population. So, what are some of the risk factors? Well, things that you've probably seen in your practice: parental inconsistency, meaning inconsistent discipline, or rigid discipline, meaning we always do the same thing regardless of the behavior. The findings are somewhat specific to negative maternal controls, probably because we have more studies of moms and females than we do of dads and males. And then negative child emotionality is also a risk factor for increased level of coercion. And we'll say a little bit about some of these and how we try to address them today. And then the effects, there are broad effects when you're exposed to coercive behavior. And as you can see here, there are physical effects, emotional effects, psychological, spiritual effects, cultural, social, and financial, meaning pretty broad consequences for an individual or family members exposed to coercion. I highlight these because these are some of the key constructs that we look for in families. And we always try to understand a little bit more about, what are the risk factors and what are the consequences, so that we could kind of better understand how we're going to treat them. Now, let's go a little bit more into the research literature and talk about the characteristics of children, of caregivers, and of families. And there are two columns on this slide and the next slide. And what you see is a column for abuse and a column for aggression. What this is saying is, if you compare in studies children who've been physically abused versus those who are similar but who have not been abused, in what ways do those children who've been abused differ from their peers? And then the second column says, if a child is aggressive, in what way are those children different than children who were not? And look at the striking parallel here. What we're really finding is, if you've been physically abused or if you have been aggressive, you are likely to show higher levels of these clinical problems. One is a broad range of behavioral dysfunction that could include aggression, poor social skills or poor social competence, having negative cognitive attributions. You blame other people or you blame yourself, or you see the world in a very hostile way. You have heightened levels of anger or anxiety, depression or PTSD. You have pretty conflicted and challenging and unpleasant, distressful peer and family relations. And there's increasing evidence that's more recent about the role of neurological problems. Now, I want to just point out that one of the reasons why this is important is because we can appreciate that kids who are physically abused often may become themselves aggressive. And so it's important for us to kind of recognize that. But I also want to highlight the fact that we're not just looking for the presence of things that are not good, that are problematic. We're also looking for the absence of things that are good. So look at poor social skills. Kids who have been physically abused have very limited social skill repertoires. That is also true of kids who are aggressive. So for us as clinicians, as providers, this is a key to figure out what might we do to kind of overcome that history, which means teaching social skills or helping to make them more socially competent. Now, it would be, I think, limited of me to simply say this is clearly related to just children. We obviously have characteristics in the literature that look at the caregivers of children who have been physically abused, and also the caregivers of children who are aggressive, and likewise the families. And the same pattern applies in our literature, whether or not a child has been abused or is aggressive. Either one of those children have a tendency to show more of these problems listed under parent and family. So they live with parents, caregivers, really, who themselves are coercive. They use themselves limited positive parenting strategies. They may have, attributions of their children that are negative, or they may have very negative expectations of their children. And those caregivers also have a fair amount of sadness and anger, as well as potentially PTSD. And then finally, look at the families. Yes, makes perfectly good sense, but it's nice to see the science, which says if a child has been abused or a child is aggressive, they're more likely to live in a home characterized by coercion and conflict. They're more likely to live in a home that has very limited, low levels of problem solving, and they're fairly socially isolated. They're not interacting with lots of friends or family members or neighbors. They also have few psychological and financial resources, which says something about the context. And then they're often involved in various systems, child welfare, juvenile justice, possibly education. So I hope what this gives you is a sense of some of the characteristics that we face, that we encounter when we treat these families. And these are indicators of what we may need to target if we're going to try to overcome them, as well as improve, the life course of these children. So let's bring this to the clinical level a little bit. And I'm sure you all have different experiences seeing these families and seeing different behaviors that they exhibit or that they present with. I wanted to just share a few from our work. And these are some of the challenging behaviors related to the history of physical abuse and aggression that we see and we face. And, you can appreciate how each one of these may be a risk factor for, poor engagement, poor participation, and ultimately maybe early departure from treatment. And they're all characteristics that aren't simply ones that we can dissuade by persuading someone. So we can appreciate when someone doesn't want to change. Their view may be that they aren't the problem. And so this isn't something one can easily simply say, well, maybe you might be. We often try that, but there are things we have to do to help someone kind of see that they're part of this problem. The second is that minimize their abuse. Many of you have probably had the experience I've had where you mention something to a caregiver about what they've done, and they say there's nothing wrong with that. That's what I did, or what my caregivers did, or my neighbors do, or whatever. And I don't see that as abusive. I don't see that as a problem. I don't see that as worthy of being involved in the system or getting services. We have to respect these things, but we also have to try our best to address them in ways that maximize the likelihood they can participate in treatment. Maybe dismissiveness. I don't know why I need any help. I'm not even sure that you're the one to provide it. They can challenge your authority. I have many clinicians who are young. They may not have families. They may not have partners. They may not be from the same, walk of life. There are all kinds of reasons why our authority can be challenged, and those I appreciate are real. We have to understand and work with those, but we have to also be mindful of them. And then the other ones here, again, I don't know if you've experienced this, but I have. And those are things like people getting very angry at us for working with them on these issues, being very hostile about the referral, about us, about our setting, about our treatment, maybe even um, being hostile, saying certain things, swearing, getting very loud, things along those lines. And then finally, things like threats, threatening you. Like uh, we have had parents who have said, if you tell my worker about anything like this, or if you do this, or if you do that, you know, I'm going to get you, or I'm going to hurt you, or I'm going to come back at you, or I'm going to complain about whatever it is. And by the way, um, in some cases, fortunately, I think this is fairly rare. Uh, Caregivers have been aggressive. Okay, they have lashed out at people, they have thrown things. Um, so this is important for us to recognize, I think, for a couple of reasons. One, we have to understand where our clients are. Okay, and I realize that in many cases, you may experience this before you've ever met someone, before they have ever gotten to know you, you know, that this comes with this terrain, and we have to be respectful, but we also have to be aware. And we have to also be aware because we have to make sure that we can respond appropriately to these things. We have to know how to address these types of challenges, reactions, because they are the reaction that sometimes accompany families in this clinical space. But it also means that we need strategies and we need agency policies and procedures to help us deal with this. And I'll say something about this towards the end, but I really do feel like it's quite important if you're going to work with families, enough families like who are characterized by physical abuse or physical aggression or conflict and coercion, for us to have these strategies, in place and to be thinking carefully about how we, both as individuals and as systems, agencies, clinics, maybe some of you are in private practice, so your practice, handle these things because they come into the door, right at the very beginning of treatment at times. That doesn't mean they couldn't either be initiated later or reemerge later, but we have to be prepared for dealing with these things. And I don't want to make it sound like they're simple to deal with. So I would just encourage everybody to be thinking carefully about all of these issues. Okay, so I just have a couple more slides, and then I think if we have time, we'll see if there are any questions. It's always good when one can to address them as you're having them. But I do want to spend a few minutes on this slide and maybe a couple of others, because I think it also highlights one of the challenges in working in this area as well, which is we recognize we're going to have caregivers and children who may be quite angry, irritable, upset, distressed, agitated at many things. Some of those things could be their life, what happened to them, the system, child welfare, mental health, but it also could be that that is displayed to you, to us. And so one of the things we have to really appreciate is that there is no one form of anger, or let's use the term for the moment, emotional abuse. You know, Parents and kids say many things that are hurtful, words that hurt. I'm sure you've heard the term. And, there is no list of all the possible words that can be hurtful because we could not list them all. There are just so many. And one of the things that we have to kind of think carefully about is how to spot them, how to recognize that this is what's going on, and sometimes we listen to a couple of terms and maybe it may, upset us a little, or maybe it rubs us the wrong way, or we're a little uncomfortable. But as you start to think about what is being said and to whom and how often it might be said, and don't forget that's in your session, you might be thinking about, well, what are the things that come up, in the home? Okay. And I want to highlight the fact that there is this continuum that we really should be mindful of. And this is on the verbal side. I'll show you the physical side in a minute. This is the verbal side. Verbal hostility takes a lot of forms. There's no checklist, at least no checklist I'm aware of, that can kind of say, here are all the negative, nasty, hostile, angry, unpleasant, distressing, humiliating, insulting things that a caregiver can say. And yet, we need to be aware that they can take lots of forms, and we won't know which things said are hurtful, like felt as hurtful to a child. These are just some examples you see on this slide. And this is from a paper that was published probably not quite 20 years ago. And they tried to organize, based on feedback from professionals, going from the left to the right, those verbal hostile statements that were seen on the left-hand side as maybe less serious, and then it proceeds to the ones to the right, which are a little bit more serious. I'm not here to defend the scaling. What I'm appreciating is their recognition that there's a continuum, but there are many, many forms. And this is why we have a lot of trainings and a lot of focus now on emotionally abusive behaviors, because we have to train our ear to be sensitive, to hear these things and recognize that we need to learn a little bit about how often they occur, what's their impact, who says them, when are they said. And this is a very nice demonstration from that paper to me of our need to be sensitive and also to take note, and then to actually focus at some point on ways to learn about and sensitively, and I mean empathically, discuss the things said, between children and their caregivers in our treatment. And I will show you a little bit of how we do this in AFCBT. But this is just one of the important continua that we look at. And why is that the case? Well, one reason is that sometimes these comments, as you know, are the precipitants for more serious, problems in the family, whether that's child problems or parent-child problems. And that includes the use of force. So let me just say something about force. And again, there's not a great word. I don't always want to say physical abuse, because as you know, physical abuse is only a small portion of the physical force that's used in the world. And even if you think, and I can appreciate this, that any type of force could be abusive in our legal frameworks, we have a more restricted definition. Now, who knows if that's going to change in the future, but for now, that's the case. But just because it isn't illegal doesn't necessarily mean it's good clinically. So we try to look at all forms of physical coercion or physical force. And this is from the same study I just mentioned. And so they tried to get feedback from professionals who organized a set of responses and indicated which they thought were the most serious in terms of, impacting children adversely. And this likewise goes from pushing and shaking and spanking, which were kind of rated on the lower end, all the way up to attacking with a weapon and sadistic torture. Now, you might be thinking to yourself, well, shaking a 1-year-old or a 6-month-old is definitely not on the low end, and you would be right. We know that. I don't think this was meant to capture this based on kind of developmental differences. It was probably with reference to a 10-year-old child, or maybe the typical child coming to a, either mental health or child welfare setting. But even if it isn't accurate to depict the severity across all the age ranges, I think the value of this is that it makes us more aware that there are lots of forms. There is no way to easily like assess, you know, all of the things that a parent can do to hit or, use force against the child. We just can't easily list them all and ask parents to think about that. Here's one quick example. Maybe this is true for some of you. And I'm sure you have a lot of diverse experiences that are really important and worth understanding. But we have had some parents who have made their children kneel on hard rice, for like 30 minutes. Well, one of the things that does is it, cracks your skin and you bleed in some cases. So, you know, I would never have thought to either ask about or even look for things like that. And I remember that was one of the circumstances. What it should hopefully tell us is we have to be really good at learning about and then asking about a whole set of things that we might not see in a referral form. It may not have even been something that the parent tells you right away. You might hear about it later. So we just have to be open to the fact that there are lots of forms of anger or emotional abuse, and there are lots of forms of physical force, or in some cases, physical abuse. And I'm saying that because AFCBT really targets as best it can those domains. Okay, this is really meant to reduce the level of emotional abuse, as well as physical abuse or, conflict and coercion, if you will, more generally. But so, so I hope this has made sense, and I hope it also fits in with maybe your clinical practice. And to the extent that you are going to see, let's say, more families like this, then maybe this is going to help you be a little bit more aware of what's being said and not to dismiss certain things that sound like they might be benign. Because here's one of the challenges. None of us really knows how these impact kids. The only way we really know is we have to ask and we have to look around and kind of work with the family and see. Okay, and I'll show you a case soon that kind of hopefully makes that point a little bit. But this is meant to help all of us become more aware. And then, of course, not only being more aware, but we have to think of ways to respond to caregivers and children when they tell us these things have happened. We need our own ability to empathize and to be supportive, even if we recognize those are worries and concerns that we are going to try to overcome. Okay. Oops, sorry. So let me go to this slide here, which kind of helps us conclude at least this initial section for the moment. And this talks about understanding the context of abuse. And I think what I've been trying to do is also round out the context for, conflict and coercion. So we're all more broad-minded in our abilities to discriminate and recognize and appreciate all of these things going on in a home that may or may not have been part of an assessment or part of a report are on our radar. We're aware of them. Okay. And I wanted to highlight, the context of physical abuse and discriminated from the context of sexual abuse. And what you see here is just a table with some different parameters, and the first one is kind of our societal context, right? In our society here, in our country, it is unacceptable, to have sexual behaviors with children, to engage in sexual activity with children. There are laws, and even though people break those laws, we know, most people know, it is not appropriate. Um, but when it comes to the use of physical force or physical discipline, our laws say, and this is true in every state, that you're allowed to use physical force. Now, you might be thinking to yourself, Yeah, but you're not allowed to physically hurt or damage, okay, or injure or harm a child, and you would be right. Like, I get that. We have laws that say you can use physical force, you can use physical discipline, but, the abuse laws, which do vary by state, but for the most part, they say, if you really injure physically a child, and there's kind of a, if not permanent, at least temporary set of injuries, signs, that in many cases is considered physical abuse. But this is an important distinction because when we work in this space, we don't have social norms. We don't have a law that says you can't use physical force. Okay. Parents are aware, just as we are aware, that they are allowed to use physical force. And in our treatments and in our conversations, we do not say to them, you are not allowed to use physical force, because they are. Now, in some cases, when they're in the child welfare system may have its own laws and rules that may say that that if you do that, this is what's going to happen. But the legality generally is such that there is no law. Okay, it is not a crime to use physical force. It is a crime to be physically abusive. And that means we have to recognize that, and we have to work with that. We have to work with the fact that we're now going to have individuals who may feel they are doing something that is both legal and, in their minds, rational or reasonable or appropriate and acceptable. And we need to be able to meet and greet that as best we can. Now, there are ways to help them see maybe that what they're doing, however legally appropriate or legally permissible, is not clinically valuable or helpful. But that's where our clinical sensitivity, right, and training come into play. But it's important to recognize that. The second thing I'll point out is the targets are quite different. The general target, I'm not saying in every case, but most cases, in sexual abuse, the primary clinical problems that we treat are anxiety and depression, especially PTSD, which is an anxiety disorder. Whereas in physical abuse, the primary clinical targets, just as I showed in the prior slides, are physical aggression and hostility. And so we now have to be thinking about, how do we target? I mean, if we're going to work in this space, we're going to recognize that those are the targets. Those are the things we're going to try to modify and replace. But the other thing to be aware of is that the alleged perpetrator, so-called, in sexual abuse cases, is almost always, if not always, removed from the home, or a child is removed from the home, but they're not together. Whereas in this country, and at least in my state, and maybe in New York State, there are many families who stay together. The perpetrator, the caregiver, is still in the home, and the child, even if removed temporarily, or if one of them is removed temporarily, in many cases they are returned, either quickly or with other plans, reunification plans in place. But in many cases, neither one is removed. And so this tells us that we have to be able to recognize the increased risk of working with a family member, a child victim who is also living with the perpetrator. But we're also now aware of the fact that we have to work with that, again, so-called offending caregiver, whoever is alleged to have engaged in aggressive or abusive behavior to the child. That means our treatment has to incorporate both the victim and that perpetrator, and think carefully about ways to address their respective needs, both as individuals and as a family. And then so what you can see here for family is, in a lot of cases, I won't say this is every case, the families referred for physical force or physical abuse, they're not necessarily that supportive of intervention. Whereas in many cases, there are supportive caregivers to work in cases of sexual abuse. Again, I'm not saying that's always the case. but it's another one of the indicators of how we have to kind of recognize what our repertoire needs to be, because we have to be able to work with families who are not necessarily going to be supportive of us or our work or the need to change their behavior, which is why I showed on the slide earlier some of those responses. Um, we accept when we have this type of case a high potential risk for safety concerns like injury. When caregivers who have engaged in these behaviors are still with their kids in their home, and it's something we all have to do. This is partly something we have tried to address in our treatment. And then finally, I just want to say the caregivers in this particular treatment, than most treatments for physical force and conflict, they are, if not the primary client, they are as important as the children. Whereas in sexual abuse, usually more time is spent treating child victims, but we have to spend a little bit more time on both. And I just want to highlight this, as we get into this treatment, because I hope what you'll see is how we're trying to address these issues to some degree in the assessment measures and in the treatments that we use. So I may have a couple of minutes to answer a question or two if there are any. And I'm going to ask Diana if we have any. And if so, you can maybe tell me and I'll do my best to answer them.
Sure, Dr. Kolko. So yes, just in the interest of time, we did have a couple of questions come in, but I will look at the very last question that came in through the very chat box. All the other questions, again, as a reminder, please continue to put them into the chat box, and we will do our best to get through as many during the Q&A portion at the end of the webinar. So actually staying on this chart right here, Dr. Kolko, in terms of understanding context of abuse, one question that came in is, why is safety risk for sexual abuse considered low? The long-term effects of sexual abuse typically leads to high safety risks. Even short-term safety risks are present with STI.
Yeah. Well, I mean by safety, the risk of that child being injured or hurt. And in that regard, at least from the literature I've read, the likelihood of them being injured or hurt by a caregiver or someone in the home is kind of low. I think I am not speaking to what I think your question's getting at, which is, do they have subsequent problems later on? But that's not what this item is actually speaking to. This means safety risk at the time of treatment. In general, at least from the literature I read, it's been fairly low. Like, for example, there are very few other reports that have been noted in studies that discuss treatment of sexual abuse. For example, filing with Child Protective Services, whereas that isn't the case with physical abuse. So that's really all I'm confining this to, which is the likelihood of physical injury or safety risk in the home versus the home of the physical abuse victim. So I hope that answers your question.
Great. Thank you so much for that clarification. And again, yeah, in the interest of time, I think we can continue
Okay,
with the presentation.
you got it. I will do that. Thank you for the question and the other questions. I'll do my best to answer them. Okay, so let's talk a little about really assessment. And I guess what really we could say is this is assessment for informing treatment or to inform treatment, because of course, that's one of the things we try to do when we do this. And maybe one of the things we could do is, we can't really discuss in the interest of time too much of what you do for assessment, but maybe one of the things you could do is just think a little bit about, what do you use? Okay. What do you do with the assessment information you get? It has various functions. I'll talk about a few in a minute, but maybe one question you can ask yourself is, do you provide feedback to the family? Not even just, it's important to understand how do you do it and when do you do it, but maybe those are too challenging. But maybe if you provide feedback to the family or if you don't, that may or may not, maybe that's something you could put in the chat, yes or no. Do you provide feedback to the family? And I'll give you a minute just because it might be helpful for us to know a little bit more about your general practice about giving feedback or not. Maybe you could just take a minute.
Yes, and we are seeing responses coming in, Dr. Coco. I will also just refer back to the first poll question of do you routinely treat family conflict? We had about 2 out of 3 individuals say yes, they do
Yes.
routinely treat family conflict. For the second poll question, do you routinely treat families where physical force or aggression is used? We had about the same number of respondents, but here the answer dropped in terms of yes. So what we're
Right.
seeing is that people are treating family conflict, but when you ask about physical force or aggression, the number of yeses drop and it's more of a no. In regards to this question here of providing feedback, we are getting a combination of things, but more often than not, I'm definitely seeing more yeses than nos to this
Okay.
question.
Great. Okay. And then maybe I'll ask you one other question and then we'll move forward. And if it's okay, please just put something in the chat. And that is, do you re-administer what you already administered at intake or baseline, whatever you call it? Do you re-administer any of them at discharge or when you're done? Yes or no? And again, this will just give us an idea about what kinds of practices you utilize generally for assessment.
So we are seeing majority yeses, a few nos trickled in there, and then some caveats depending on the nature of the work or depending on the client.
Right.
Um, but yes, I'm going to say more often than not, I'm seeing more yeses than
Okay.
no.
All right. Great. I appreciate your giving me that information, and I appreciate the fact that you're saying, for the most part, you do these things. I also recognize there are times when one can't, but I want to talk a little bit about maybe the role of assessment in the hope that maybe this helps to establish a structured way to do it, along with the importance of doing something like this. And I think this is probably true in all of medicine, including behavioral health medicine, right? Which is, assessment is really part of the treatment plan. Think of any place you go for a medical appointment. Um, there's almost always at least one assessment or an evaluation. And in many cases, there are tests and all kinds of things to help guide treatment. And it's probably true that we would benefit to the extent that we had more information that's accurate about a family's, needs or problems and goals, things like that. So, this is what I guess I'd like to say about what one might do and then how to do it. I'll say something about in a moment, which is we think it is really important to do an initial intake or whatever you call something at the beginning. And the point of it is to get anything clinically relevant that can help guide treatment. Now, there are so many assessments, and I know all of you come from very different, settings and agencies, and you have your own policies, and I appreciate that, just as my clinics do. And but this just seems like a really important thing for many purposes, and I'll talk about those in a moment. But one is to at least do something at intake. The other is we think of trying to get ongoing information during treatment, and the point of that is to monitor the response to the treatment on certain key clinical, targets, problems that you are really quite concerned about. Those of you who work with suicidal individuals, I'm sure, get some information on their level of suicidality during the course of treatment because of the high risk nature of that case and the fact that suicidality can come and go and we can't easily predict it. And so it's really important to ask about it. So that's another reason why it's good to do this. But the third is because it gives you information at the end of treatment, or at least if it isn't the formal end, like you've done everything, at least it's at discharge whenever that occurs, because it can tell you something about the impact, both what changed and maybe what didn't change. And in my world, and I'm sure maybe in yours, we have some improvements with many cases, and we have um, times when we have no improvements. on those same cases in other areas. So we don't take for granted that we know who's improved and in what way. And so in that regard, it really seems important to have some kind of outcome assessment. The other thing I'll just say about this at the end of treatment is it's also helpful because at some point you're going to look at your cases, you're going to think about your practice, especially if you're adding this type of treatment or doing more of it with this type of population. At some point, you're going to want to take stock and say, gee, how are my clients doing? Are they improving? Are they improving on the things I've targeted? And if not, what does that mean about either them or me or us and our system? And so it really is important for that information. And then the final reason I'll just say is that imagine, you have a client who's in another system or two, and now your collaborators in those other systems want to learn how the case went. Well, when you do this, you're able to give them more information than simply here's what they did or here's how they attended and here's what I think. It's a little bit more information from a client's perspective. And so for all those reasons, I think doing it has value. So what are some of the constructs, the indicators, the targets that we think of for dealing with, family conflict? And these are ones I've already said a little bit about. And some of you are probably experts in certain ones, or maybe all of them. And others are experts in different ones. Like some of you may be very good at treating PTSD, and that's what you focus on. And maybe others are really good at dealing with and treating parenting problems. And then maybe others have other expertise. What we're trying to highlight here, these are some of the common problems based on the slides we've kind of talked about, but also based on our cases that indicate some of the key constructs that we believe we may have to treat. And if we have to treat them, we may, of course, need to assess them and assess them carefully. Now, I am not an expert in all of the assessments that are available in the world. And I read about some of them, and I know a little bit about a few. So I have my own set from the work that we do in AFCBT, and I just wanted to highlight them. And again, I'll just simply say as a disclaimer, there are people who have far more expertise, and they are really experts and know a lot about many, many, many more assessment instruments, especially newer ones. And while I try to remain current in this area, I am not an assessment expert. I just know a little bit about some of these tools that we have used in research and we've used clinically. And I just want to give you some information about those. Here are 4 listed on the left-hand side. I don't know if these are ones anyone uses. The Alabama Parenting Questionnaire, the Brief Child Abuse Potential Inventory, we call it the APQ, the BCAP, the SDQ, Strengths and Difficulties Questionnaire, and the Child PTSD Symptom Scale, or the CPSS, all the abbreviations. And I just want to say a little bit about these. Now, these can be completed on paper, they can be done online, they can be done as an interview. I could appreciate that your clinics and your programs use different strategies and you have different resources. Some of you do your own intake, some of you don't. Some of you do them face to face, some of you don't. They're all good. You have to use whatever are your clinics, your agencies, your practices, strategies that work for you. The good news is they've been done a lot of different ways and they seem to hold up psychometrically either way. And that's one of the nice things about these tools. They do have very good psychometric properties, meaning they seem to measure what they say they're going to measure, and they measure them reliably, consistently. And that's an important set of features for using a tool. And then the other thing I'll say is they've been used across a lot of different forms of trauma and age ranges and settings, and types of studies and cultures, as well as other backgrounds. And that's one of the nice things about these. They've been around The SDQ is, I think, in like 20 or 30 languages, probably is the most globally used of all of these tools. But you're welcome to look up, and I'll show you the references for these. They're in the slides a little later. But I wanted to just tell you a little bit about each tool. And then what we'll do is I'll show you a case where I'll just give you a few details of the case, and then I'll show you the scores. And I'll ask you to put in the chat whether you think any of the scores indicate a clinically meaningful problem based on the cutoff for that particular scale. So here's the Alabama parenting question. And again, for those of you who use this and know it, I'm sorry this is redundant, but maybe for those of you who don't, this might be valuable. All of these are picked because they're fairly short. This might be the longest at 42 items. There is by the way, this is the regular version of the APQ. There is now a short version, which is much shorter, and it has most of these factors, although it does not have the corporal punishment factor, which is only 3 items. But I'm going to talk about the parent measure overall, the broader one, which has 42 items. But you can look in the literature to find the short version, which is derived from these items. Basically, this is completed by the caregiver. Now, there are some clinicians who use this with youth. Like, I think just 2 days ago, actually, I was meeting with someone in the military who has a client, and this form was administered to the dad and a teenager. And so I was able to actually see the scores for both. And what was interesting about it was the caregiver rated himself very high in positive parenting, and the youth rate him very low in positive parenting. And then the opposite was true for the corporal punishment factor, which was the youth gave a very high score and the caregiver a very low score. We don't often do it with teenagers. Like, this was his prerogative. We usually use this with the caregiver, but if you have a reason to do that, you could. Okay, there's nothing against it. You just have to understand it, and you have to, explain why you're doing it and all of that. But essentially, this is a measure to capture the factors you see listed below. And again, I'm talking about now the longer version. So positive parenting, negative parenting, which includes inconsistent discipline and poor supervision, and in the longer version, corporal punishment, and then some other actual punishment practices. Okay, now, hopefully what you're seeing is this is directly relevant to all of the things I've just said about what does the literature suggest are some of the problems that caregivers come in with who are in this space. Okay, and this is why we have this tool. And I just wanted to show you a couple of examples of APQ questions. And again, this is from the longer, full 42 item original version of the APQ. What I like about it, though, is it's an easy scale to understand, and the items are written for the most part to be relatively straightforward. Straightforward language, not too jargony. Okay, I realize we might object to the word obeying, which probably highlights this is a little bit old. And you could always think about how you explain this to a teenager or a caregiver. But basically, this is the tool. I just want to show you some of the item content. And this content then is connected to a set of different constructs or factors as the ones I mentioned. And then you get scores to indicate how much or how little of each one. Okay. And as I mentioned, you can do this with the teenager, but let me also suggest you may have 2 caregivers. And if you do, you can do them with both. Okay. I usually ask them to fill them out separately and not to discuss their answers, because the whole point is to find out what they really say about themselves. Okay. Without it being influenced by someone else's point of view, even though that isn't always something we can change. But we try to say, you fill out your version, you fill out your version, and I'll look and you score them separately. Okay. And there are times when caregivers who have filled them out independently roughly report the same things. And as you all know, there are times when they report really different things for one another. Okay. So this is why it may be valuable if you have more than one caregiver to ask. Okay. Now, what about the brief child abuse potential inventory, or what's called the BCAP? The original CAPI, child abuse potential inventory, is 160 items, and that's really long. It's a great tool, but it's really long. And so it turned out not to be as feasible for us, but there is a brief version that was developed by Steve Andersma and colleagues. And it's in the literature, and it's based on, a subset of CAPI items, and you can see 34 instead of 160. What's nice about it is it includes some validity scales. So these are scales that help tell you, can I believe the scores? Does it seem like this has been completed carefully, or does it seem like someone is actually answering questions in a way that are really unlikely? If so, maybe they are just trying to look good, and who knows if that indicates that they may not be answering the rest of the questionnaire accurately. There is no easy way to figure out if someone is not telling you the truth, but this is an attempt to at least tell you something about whether it looks like it's a valid profile. If it's a valid profile, then what's interesting about this measure is it has a risk for abuse scale, and then it has 3 items for a family conflict scale. And I am using this tool because of both of those are relevant. The risk for abuse scale is, imagine you have a family and you're now worried about them crossing over into becoming physically abusive and worrisome. And you can use this tool to maybe help you determine how close to that are they, and do they seem like their potential is lower at the end of treatment. And then I'll show you the clinical cutoffs for these in a moment, but this says, there's a criterion that you can use to indicate whether or not there's heightened risk for abuse. And again, these are just some of the items. And, this is a scale that actually is completed with a different response scale. It's basically you agree or you disagree. It's dichotomous, which is easier for people generally to fill out. It's a shorter scale. And as you can see, the items to the left, I'm a happy person. I sometimes act without thinking. I'm often lonely inside. My family fights a lot. Again, some of these, as you could appreciate, help us understand what is it we might need to target. Especially a caregiver who says we fight a lot. Well, okay, now I can use that to not only understand the risk for abuse, but also have a conversation possibly about why and when and who and how seriously and things along those lines, because those are, pieces of information that often don't show up in a report. We just don't often have good information about, family interactions and what they do. So again, this is meant to give us information that may not be easy to assess. And also, I realize it's a sensitive piece of information. Okay, so let me talk about the strengths and difficulties questionnaire, the SDQ. This is a very short rating scale, 25 items, and it has, basically 5 factors that get summed to create a total. I don't know if any of you use the child behavior checklist. Maybe some of you do. That's a much longer tool. This was partly, I think, designed to really offer an alternative to a really long scale that captures information about child psychopathology and some of the social and peer competencies that are important to assess. And it does a pretty good job of it. It's really well studied. As I mentioned, it's translated into a lot of languages. It has been studied in multiple cultures. And I think for that reason, the factor structure is pretty robust. And that has also helped to improve some of the language in the items. And I just wanted you to see on this slide some of the factors. And, I've mentioned from the slides that, kids who are aggressive or kids who've been exposed to, physical coercion or physical abuse, have heightened aggression and behavioral problems. So this is nice because it has a conduct problem scale. But I also mentioned those are kids who also maybe, have heightened anger, and so you have an emotional problem section. Um, I mentioned that they don't necessarily have good peer relations or really good social skills. Well, that's why we want a pro-social behavior and a peer problems. And each of these are 5 items. So they're really quite short. They're thin, you know, um, and yet they have pretty good validity. So here in a pretty short instrument, you can get a kind of a sense for many of the clinical problems that I've talked about already that come with the clinical space we're working with. And again, I think the whole idea is get valuable information, but in with brief and practical measures. And that's what I'm trying to do here is use tools that are fairly simple, not too long. In other words, they don't take too long to administer, but they have clinical value and meaning, and they lend themselves to repeated assessment. Okay, here's just an example of SDQ items. And, here yet again, another scale. We had a 5-point, we had a 2-point, now we have 3-point. And, again, I don't develop these. These are existing tools. We use them as they were standardized and developed. But, for the most part, parents can do this and do this, reasonably quickly. And again, I think for the most part, the language is pretty understandable. Often complains of a headache, a stomach ache, or being sick. Yeah, I can relate to that. Losing their temper. Okay, I think I understand. Like, for the most part, this sounds like pretty reasonable language. I'm sure one could do a better job, but this is one of the tools. And again, it had pretty good generalizability. So it may actually be helpful to you for capturing those particular problems I just mentioned. Okay, and then the child PTSD symptom scale, which is a self-report, although it also has an interview portion, but it gets at a certain type of, what's the main or an important traumatic event or experience, and then it asks about, PTSD symptoms in children and adolescents. And so it goes through DSM-5 criteria. So it pretty much follows the DSM in that regard. And you can use the first part to learn about a traumatic experience as an interview. There are some practitioners who use this tool as an interview, especially with younger children. There are some who might use it as a self-report, the clinical scale for older teens. Everybody has to decide what works best for them. And I would just say to you, if you were to use this tool, you can decide what works best. There are times when an interview is helpful, because you may not think someone can read it well, understand it well, and you want to be able to explain things because maybe they need some support in that regard. Maybe they need a little extra structure, a little extra motivation to fill it out. On the other hand, there are times when that's not needed, in which case someone could do it as a self-report. And then as you see at the very bottom of the slide, it talks about a clinical cutoff, which is really good. It has a clinical cutoff. A 31 or greater is kind of the cutoff for likely having PTSD. Okay, so that's kind of a nice indicator of someone is now looking like they have primarily the symptoms of PTSD. So that's what's often used as their clinical cutoff. Okay, and here's some examples of the tool and the items to get at the screen. And this is really the item around what is the event. what is the experience. I just wanted you to see some examples of that. And then these are items to capture PTSD symptoms. So this is kind of a two-part assessment. And what I think is meaningful here is that we often think that the main event, if you will, the main traumatic experience or event is what they're being referred for. And in many cases, that may be true. But having done this a fair amount, sometimes what we've learned is it's not. And what we really try to do is figure out, well, what is the most distressing thing? And then to figure out relative to that, to what extent do they have PTSD symptoms? I mean, that's how this tool was designed. Now, you may decide that you're interested in more than one, and I can appreciate that, and in which case you may have a willing client who can do that. But generally, this is how this works. And I'm just pointing that out because I can appreciate that no one tool is perfect. No one tool does everything we want whenever we want it and with any client we have. And I want to make a comment just about assessment in general that I made before, and I just want to reinforce it, which is there is no tool that gives us the truth. We're always assured we're getting the truth, and it's complicated. What's in the head of a person being assessed? Think about your own experiences. If I don't trust you and I don't know what you're going to do with the information, I might not tell you the truth. I may have good reason. We don't have a truthometer, and I accept that. Now we have to do things that set the stage for people to trust us, to want to give us the truth, to trust us with their vulnerable, experiences and things said that they don't tell anyone that really are upsetting. Okay. And that's not easy to accomplish. Setting that stage is not easy to accomplish. So I'm just pointing it out to highlight that that is one of the limitations of every self-report. Okay, which is we have no way to guarantee that it's accurate. And so we try to say and talk to people about doing whatever it is they can to help someone understand what they're doing, how it's going to be used, where it's going, how it's going to affect them to the best of your ability. So I just wanted to point that out, that no tool can overcome biases or prejudices, and that's just something we all have to recognize. I'm sure you do, but I just want to make the point. Okay. I want to say something just about the targets, and I wanted to give you this slide, which just highlights for each of those tools a couple of the very key constructs and the number of items for those constructs in those tools and the clinical cutoff. So you have this as a reference. And I will show something like this to you in a minute, but I just wanted you to have it in the slide. There are other factors in these scales that are important, but these are some of the ones I use the most, and I just wanted to put them on this one slide so you'd have it, okay? And this tells you on the far right what the clinical cutoff is. So, if you get a score of 9 on the corporal punishment subscale, that tells you this is kind of a significant problem, okay? Likewise, if you get a score of 10 below the cutoff, okay, that is a problem for positive parenting. That means you have a high level of corporal punishment and a low level, and an unfortunately low level of positive parenting. So that's how these are used. Okay. All right, so I'm going to show you 2 more slides on assessment, and then I'm going to have one final slide before we take a break. And for these 2 slides, we're just going to practice something. And this is the case, a different name, but we're calling this case Danny. Okay, this is a 10-year-old African-American boy who was living in an inner city, an urban neighborhood, basically. I'm giving you very limited detail. And this child lives with his mom, and who is the caregiver, and he has two younger siblings who are age 4 and age 6. Okay, so 4, 6, and 10. The 10-year-old is the referred child. Okay, and I'm giving you again very limited information. Um, this is a case where there was identified physical abuse by the mom, who explained to the practitioner that she needed to use daily whoopings of this child. Okay, there was more information, but I'm trying to just give you a quick snapshot. And in addition, the clinician had asked questions about other things done to manage and discipline, and learned from the mom that she used these very kind of demanding jobs and chores when he misbehaved. He had work details when he misbehaved, and they were quite demanding and time consuming, similar to what you might even find in the military. And then the other thing I just want to highlight is there was a history of domestic violence, of IPV, between the mother and an ex-boyfriend. That's what you know about this case. Sometimes this is all we know about a case where we might do assessment or do a pre-treatment evaluation. So I wanted it to be similar to the real world. I want to just show you this slide, and I want to ask you to look at, I've kept the scores, okay, that this caregiver reported and that the child reported on the CPSS. You can see that under the column that says score. That's the actual score for this case. And then the cutoff. I've copied the cutoff. And I want to just ask you a question, and you can put it in the chat, and Diana can tell us. Do you think any scores are of clinical concern? Yes or no?
Yep, so I'm seeing a lot of yeses come into that response of, do you see any scores that might be of clinical concerns? Yes, yes, and
Okay. Thank you, Diana. Great. Yeah, there are. And if you take a look, there is a high score for corporal punishment on that score because above the cutoff. There is a clinically worrisome low level of positive parenting, meaning it's below. So it's falling in the clinical cutoff by being low. The abuse risk score is high, meaning above the clinical cutoff. They are at the clinical cutoff for family conflict. And the caregiver has rated Danny's conduct problems as above the 4, which is, in the clinical range. Now, Danny himself, for at least post-traumatic stress symptoms, reports a very low score of PTS, well below the clinical cutoff of 31. Okay, so that's the only one that hasn't reached the clinical cutoff. Okay. So I just wanted you to see this is how we use the cutoffs. And this is, again, the start of possibly a conversation with the caregiver about these scores. Now, I just added these other 2 questions for a moment. Would AFCBT seem to be appropriate? Well, AFCBT does target, as I mentioned briefly, and we'll talk about AFCBT after our break, aggression and anger problems and family conflict and things along those lines, plus the use of harsh discipline. And it also tries to help minimize, post-traumatic stress symptoms, even though that isn't necessarily a big problem here. So in all likelihood, it would be appropriate, but I guess you can answer that question at the end of this presentation, okay, to see if you think it does. And then I want you to just think about what feedback might you give to the parent about these concerns. Why? Because it is helpful, and this is related to the question I asked earlier, which is many of you, if not almost all of you, said you give feedback. So you can think about what feedback you would give to this parent. Would you tell them? And how would you tell them? Here are the scores. Here's what this tells me. By the way, I never give scores. I just give what we've learned, is that you report using, needing to use a lot of physical discipline, blah, blah, blah. Okay, so, but it's an important um, piece of feedback to think about because you want to be sensitive and caring. And you also want to be empathic, but also you want to set the stage for what might treatment target and why. And this is kind of a guide to why you would target these things because you're getting it right from their very assessment. Okay, so I hope you're thinking about that. And again, I'm sure you have routines or someone who does your assessment has a routine, but it's really important to think about how we give this news. If we went to an oncologist and we just got 7 tests and we have fourth stage cancer, that answer, that response to me or you is really not just simply, hey, guess what? You've got stage 4 cancer, you got a month to live. Can I answer any questions? I don't assume it. So, and I know people who've had it and they've told me how this experience has been conveyed, and sometimes not so sensitively, but most of the time, yes. I take that example because, you know, who knows if someone sees this in a similar light, like this is really worrisome, upsetting, distressing. Okay, you may be the first person to kind of give feedback like this. Okay, so it's just something we have to be thinking about, and I hope you are, and I'm sure you are. And then the last thing I want to do before our break is to have you think about this because we're going to start treatment in a couple of minutes. I think we'll have time, I hope, for a question or two. We'll find out from Diane in a moment. But I do want you to think about, you've already said you do address conflict. So that's great. I'm glad. Now I'd like you to just think about in the break a bit, you know, what do you do? I want you to be thinking about what are your go-tos because I want to talk about a few and we'll see if those are similar. Maybe they are, which is great. And if they're different, maybe they add to your repertoire. Okay. But let's at least be primed to be thinking about, well, what are the strategies I use? What are my go-tos when I have a family like this?
I'm going to turn it back to you, but I will say that we have had some folks chime into this question, and what I'm seeing is multifamily system, parenting skill courses like the Triple P or Safe Care, providing assessment and short-term counseling. In initial assessments, they do help to identify root causes of conflict. DBT, interpersonal effectiveness skills, especially regarding communication skills as well. Also seeing psychoeducation, empathy building, role-playing exercises, safety planning, parenting style questionnaires. Let's see, empathy and education, building rapport with them, more safety planning, more DBT, and giving families the opportunity to be active participants in the decisions impacting them. So a lot of shared decision making as well. CBT, PCIT. So some of those treatments that are being used,
Mm.
Dr. Cole. So turn it back over to you. And thank you for
Oh,
sharing.
yeah, of course. Thank you, everyone. Yeah, I agree. And Diana, thanks for the update. Those all sound wonderful. I especially appreciate how many different strategies and evidence-based packages or programs all of you are using. I'm going to say a little bit about some of the strategies in AFCBT. And what's interesting is it does cover a lot of the ones you mentioned, but maybe not all of them, which is kind of understandable. No one treatment can have everything and be everything for every person. So how nice that you're using all those strategies. We'll have a few places maybe where there's kind of overlap, and maybe there are a few things that might be more novel or unusual to consider. So thank you for weighing in and thinking about it. Okay, so I'm just trying to get this to move forward. Well, let's see. My whatever has worked for me before is not at the moment. Um, there we go. So maybe it just needs time to recognize it's me. So let's talk a little bit about the intervention strategies. I'm not going to cover everything in AFCBT. That takes 2 days, and then follow-up material. But I have tried to pick a couple of things that I think are kind of universally maybe beneficial that might be appropriate for any intervention that someone is using with a family like this. And anyway, we'll take some feedback maybe later about your assessment of those things. But for the most part, what I want to highlight is there are some things in AFCBT and there are many things that aren't in AFCBT. These are some of the treatment modalities we have tried to integrate. Individual therapy, CBT, anger management, as well as anxiety management, but primarily anger management, how to manage, hostilities, things like that. Positive parenting and, ways to overcome unpleasant or unwanted or challenging or punitive or harsh coercive parenting. Some family therapy work, especially around a couple of skills I'll show you in a moment. And then for a child who meets PTSD, trauma treatment. Now, in my neighborhood, in our area, we have a lot of referrals of families to multiple providers. I don't know if that's true for you too. Chances are it is. And so we have some families with lots of providers and they're going everywhere. Okay. They're going somewhere for individual, they're going somewhere for family, they're going somewhere for a parenting class or a parenting program, they're going somewhere else for trauma treatment. And it's just so much wear and tear. And so when we were thinking about what made sense to incorporate that would be reasonable to incorporate, these are the things we put together. Why? Because maybe you can get more of what is needed for most families from one provider. And it would reduce the wear and tear on the family, but it would also increase the ability to coordinate care because the same person is doing these various things. So that's one of the reasons why we have integrated this and why there is a lot of content in AFCBT. There are times when I think maybe there's too much content. You can sometimes wonder if maybe there's just too much burden on families, and I am sensitive to that. But for the most part, I think this was the clinical rationale for bringing them together because they often were recommended by judges, for example, and they were sending people to 5, 6, 7, 8 providers, and that's just a lot and too many in my view. Okay, so here are the steps of AFCBT. I can appreciate this may be the longest acronym in any of the existing evidence-based treatments or practices. I can't even fit it on one slide barely, but it spells out the word alternatives. You could probably see that. But what I wanted to highlight is these are the topics. I'm not going to go into each topic today in any detail. I do want you to recognize kind of what they are. So we have three, phases. They're listed at the top left. First phase is engagement and psychoeducation. Then we move into individual skill building. And then we move into the final phase, which is family application. So in other words, for individual skills building, it's separate sessions, child and caregiver, and they're together for family application. And for the most part, they may be together for the first orientation session in phase one, but they're pretty much independently seen for the rest of phase one. So most of that is individual and only at the end is the family. And if you start at the bottom, I just wanted you to see, just to have an idea about this. We focus on alliance building. I made a point, I hope, of saying why I think this is so important when you work in this space. And we have to work hard, I think. We have to really be conscientious at being a good partner and at being trustworthy and being empathic and respectful of what has happened to a family and what the family is like and who they are and what they bring and their values and what matters to them. I mean, that it understanding that and greeting it and respecting it and trying to incorporate that in our treatment, I think, is what is needed. At least one of the things needed to help get buy-in. Okay. Anyway, so I'm not going to go into any detail on each of these now. I'm just going to show you a couple of general strategies in each of these phases in a way, and mostly in the first ones. But then the next thing we do is we try to talk to the caregiver and the child separately about their feelings about things, and especially family experiences. I'll give you an example of an exercise we do to learn about a child's exposure to family experiences shortly. But we do this separately with the caregiver in the second topic, and we do it. I mean, and actually we do alliance building with the caregiver in the second talk, but we do learning about feelings and family in the third with the child, and then we do it separately with the caregiver in the fourth. And that's what talking about family experiences is. So we actually do those separately because each one, child and caregiver, have their own take on what their family is like and what they've been exposed to. Also, caregivers may not tell us about everything that a child is exposed to. And maybe the same is true of the child. Maybe the child won't tell us about everything they're exposed to, and the caregiver will. So we think of those as really important to capture kind of separately, because you're asking about positive and negative things, and maybe one is less likely to want to report them for whatever reason. Okay, so that's why we do it that way. Now, once we've done that, we cross over into the second phase, which is all skill building done individually. So we do emotion regulation with the caregiver. Then the next session, once that's done, is emotion regulation with the child or teen. We do a restructuring thoughts with the caregiver, and then we repeat it, although it's slightly different, with the child or teen. We do noticing positive behavior with the caregiver. So those of you who said that you use a lot of positive parenting or parenting strategies, this is probably one of the things you do too. We then have the child and we work on assertiveness and social skills. As I mentioned before, the literature shows that these are deficits, they're real deficiencies in kids who've been exposed to physical abuse or who are aggressive. So that's one reason why it's here. And then we have techniques for managing, unwanted or problem behavior, where we work with the caregiver to teach them skills for, managing unwanted behavior. If a child has PTSD and meets the clinical cutoff, we would do imaginal exposure. So we have a topic that is optional in that regard. Obviously, if a child doesn't have PTS, like Danny in our case that we reviewed just recently, we wouldn't need to do imaginal exposure. And then finally, we would move the child and the caregiver together into sessions to do family work, where we work on healthy communication. We do a clarification where the caregiver has been working on a clarification letter. And I will say that this is one of those things where to get to the point where a caregiver is going to do a clarification, where there's going to be a meeting, you have to have worked on the letter and what they're going to say, and you have to have decided that they're able to do it in a way that is therapeutically beneficial for the child. Not every caregiver who's in this treatment wants to do or can do a good job of a clarification. And so if it doesn't sound like it's going to be clinically meaningful and beneficial, like therapeutic, we probably wouldn't do it. And that's one of the interesting clinical issues that comes up a lot. And then finally, before our graduation session, which is the last one, we would do solving family problems, positive ways to solve problems without the use of aggression. So I just wanted to give you in a nutshell what our main topics in our session guide are, what's in AFCBT. I'm not going to go through all of it today, but I am going to go through a few things. And I do want to I have a few slides I just want to show you, because we all have different families. They may have different needs. You may have different specialties. And so I have a couple of slides where I've tried to show you for the target on the left, here are some of the strategies in AFCBT you might use on the right. Okay, and you can see, we know from the motivational interviewing literature, for those with ambivalence, that using the decisional balance is really effective. And I'll show you an example of how we've tried to just incorporate that strategy here. Um, we teach parenting as a way to address aggression. We try to teach alternatives to the use of force, like timeout and, losing privileges and using contracts and having appropriate instructions, a whole set of parenting skills. If we had trauma symptoms, we would teach emotion reg. We may even do, obviously, imaginal exposure. I just wanted you to see some of the connections between clinical targets you may care more about on the left and maybe what strategies can be used. And by the way, a lot of the strategies we're using are part of other treatments, so they're not necessarily unique to us. Maybe some of the adaptations of them are in some cases, but for the most part, there are hundreds, as you know, probably thousands of all of these elsewhere in the literature. Different parenting skills, different emotion reg. We don't have the market on them. They exist in nature outside of AFCBT. And likewise, let's look at children. We just talked about caregiver. What about kids? Kids who have a lot of PTSD symptoms could get imaginal exposure. Kids who have negative attributions, they see themselves as blameworthy. They're responsible for their kids. I remember one of my first cases ever, a long time ago, I remember seeing in the chart, one of the nurses had written down in quotes and circled it, so we would kind of be aware of this. If I hadn't called my dad a bum, he never would have hurt me. I'll never forget that. That was kind of what she said to herself. That was kind of how she interpreted what happened. It was her responsibility. She was responsible for her own abuse, which of course is not true, right? Kids are never responsible for their own abuse. Parents choose to do those things, even if the kids do something that, the caregiver didn't like. But so there we would use cognitive restructuring techniques. Interpersonal problems, we would do social skills training. This is at the child level. And again, I'm just trying to give you examples because maybe you care most about cognitive stuff. Maybe you care more about interpersonal stuff. And I just want you to be able to find the strategies you care about and to see if they're here to help you understand, well, is this relevant for the work I do? Because if it's not relevant, well, that tells you maybe other things would be better to do. And then finally, families. With conflict, I realize we do a certain amount of psychoeducation, but we do really a lot of these things to lower conflict. You know, like we do teach problem solving to help lower conflict because if they can solve a problem in ways that aren't upsetting, distressing, elicit their anger, they may be less likely to have a conflict because it doesn't escalate. And because it doesn't escalate, they may be less likely to turn to other ways to influence one another, like being aggressive. So anyway, that is, of course, the hope. And then you can see some of these other considerations. If there's a lot of emotional distress, I don't trust my caregiver, I'm really worried about what's going to happen to me. Those may be good grounds for criteria for considering a clarification. Because you have this emotional divide based on what happened. I mean, think about it for a minute. And again, maybe some of you have had this experience in your lives. If you've been hurt by a caregiver and you're living with that caregiver and you are going to live with that caregiver possibly for a long time, if not the rest of your life, or at least the rest of your teenage years, you would be possibly quite anxious, worried, distressed, meaning hyper aroused. You might have a lot of PTS. And if that hasn't been addressed, nothing may actually change your symptoms, your experience. So wouldn't it be important to have a caregiver take responsibility and say something about it and do something about it and show how they are kind of not only aware of it and recognize its impact, but how they are trying to change and make things better. Because otherwise, wouldn't you just go through all of that time wondering, when am I next going to get hurt? When am I next? When is this going to happen? So this is the clinical rationale for doing some of this at that time. And think about the adverse effect, of being hyper vigilant. Imagine going through life being totally hyper vigilant whenever in your house and worried. Am I getting the belt tonight? Am I getting hit tonight? Am I getting burned tonight? All these things. So, how can we lower that level of arousal and worry and distress? Well, one way is by directly addressing the risks, okay, that caregiver has conveyed and has engaged in. And this is why we do clarification. Anyway, I'm just trying to show you where in ASCBT these targets are addressed. If you took a training in ASCBT, you'd learn how to do all of them. But we're just going to give some samples today. Okay, so these are, I guess, the typical skills that we think we address in AFCBT. I mean, there's a lot of skill training, but these are a couple of the ones that seem to be used a fair amount. And several of you mentioned things like decision making and parenting, and what you talked about. Psychoeducation, you talked about that too. Some of you talked about emotion management skills, or DBT, emotion regulation skills. So there's something in here there. We are all in similar domains, and we're in several, just as you may be, but I just wanted you to see these are some of the things we target. Some are individual and some are family. Okay. Some are more kid and some are more caregiver. And that's, I think, in part because this is meant to be a family focused intervention. Okay. So these are some of the things, again, that are routine. So now what I want to do is just say a little bit about some of the skills and some examples of intervention strategies that we use. I just want to give you a sample. I'm not bringing these up because they are our best, you know. They are just examples of what we try to do, because I wanted to give you a flavor of what AFCBT is kind of like. And I want to come back to a point I raised earlier, which is trust. I don't really know how to get people to trust us, when they come to treatment. I wish I did. I tried to set conditions up that increase the likelihood that I'm seen as trustworthy and I'm doing things that are trustful. But when you think about it, if you have trust, you may have more engagement. If you have more engagement, you may have more participation. If you have more participation, you may have better learning. And if you have better learning, you may have better skill application in the real world, which ultimately, all told, hopefully increases the likelihood that your clinical goals are solved, meaning less aggression and more, positive relationships and positive outcomes, like having successful family interactions, kids who are doing well in school, and kids who are also resilient and able to kind of move forward with all the obligations and the expectations that they have of themselves and that others have. That's the whole point. Okay. And I wanted to just highlight that getting trust and doing all of that means we have to be sensitive to these obstacles. Like I'm never comfortable when we see, my clinicians see families, and I think, oh, okay, this is an easy case. This is, you know what? The day I think that way is the day someone says, I don't like you, or I don't like this place, or this isn't working, or whatever. And so we always have to, I think, assume that there are things that are challenging for a family. They may not always have to do with you, but they could. But wherever they are, it's our job to kind of understand them, right? Like they don't have time, okay? Or a caregiver who believes that the child is the problem. And we have plenty of these, okay? That they've had poor experiences with therapy. I don't know if you do this, but this is one of the things we always do. We always ask them. We're supposed to always do it, I guess is what I would say. I hope they do it always. And that is ask other treatments they're in. What are they like? What do they like? What do they not like? What's helping? You know, this is really important to do. This is what Mary McKay studied for many, many years and found to be really important. Having conversations about their treatment barriers and issues. Parents who feel hopeless. Like, I don't think I'll ever get my kid back. I don't even care if AFCBT is the best treatment in the world. I just don't know that that's ever going to happen. You know, someone who's overwhelmed, they feel blamed by the system. How many, I don't know, maybe this doesn't happen to you, but we have plenty of families who are referred by child welfare. They feel persecuted, they feel prosecuted, they feel blamed, invalidated. Not all the time, but it happens. Sometimes they might even feel that way by us. Okay. They're angry about all of this. They're angry they don't have their kid. They want their kid back. You know, I mean, all these experiences with the system that have not gone well. I think we just have to recognize this happens. We need to know about them because why? We don't want to repeat it. You know, I remember a parent said to me, you know, I'm not sure I'm going to like it if CBT. And we said, why? Because I don't want my kid on medicine. And we said, you know what? Medicine is actually not a part of AFCBT. Um, and it might be part of psychiatric treatment or other things, and your kid may need it, but it isn't necessarily what we're going to do. If we determine that your kid had ADHD or depression or something in it, and medication was necessary, but that could have been an enormous obstacle and lowered their willingness to even hear us. Okay, physical and mental illness. Again, these are just things we just have to recognize. And I can't emphasize enough that some of them maybe we can do something about, and some of them we can do a little about. Um, Practical problems, transportation. This is such a big issue. Childcare. You know, everybody expects that these families can just kind of get up and go. And I've had cases like this where the first thing we worked on was how are you going to get here? Okay. So anyway, living in an unsafe or unstable. I mean, I'm not telling you anything you don't know. I just want to highlight that these are just so important and to try to understand and as best we can, I have to use overcome in quotes. Maybe we can overcome, maybe we can't. Do our best because asking them to come back without dealing with this is just, you know, a lesson in um, someone not returning, right? Dropout. Okay. I'm just going to, again, just give you some examples. Establishing rapport with the child. You know, think about these kids. These are kids who live in a kind of dangerous, sometimes toxic, punitive home environment. Their voices are not welcomed, and they are, you know, physically intimidated and coerced. Um, so when we do an orientation with both child or teen and a caregiver, we have a pullout where we meet separately with the child. Why? Because, by the way, we have a pullout for the caregiver too. And then after that, we do the child separately. Why is it important? Here's my rationale. It's going to be very hard to have that kid speak up if they're with their caregiver. And I don't know if this is your experience, but I have lots of families where we're in the orientation and you can just tell whenever the kid opens his mouth, the parent says, hey, stop it. I'm talking here. Well, that will not invite participation, engagement. Okay. If anything, it's inviting fear. And again, maybe we just have unusual cases in Pennsylvania, but I just find you have to give the kid an opportunity to kind of breathe, see you as their therapist too. And these are the things we try to achieve. You know, what do you want out of this? Okay. You know, what did you expect? Well, I was told that I'm going to be this, I'm going to be that. Well, some of those things may be true and some of them not. You may be the first person to ever ask that kid, what are your goals for therapy that aren't related specifically to the parents? Okay. And when we do this, we have a form, but I just want to highlight the principle, which is we ask them, what's the problem you want to change? And then we say, well, what would be the goal? What's the goal you want? Usually, when you ask kids, sometimes even caregivers, what goal they want, they give you perfection. They give you ideal. Well, what is a smart goal? A smart goal needs to be achievable, okay, practical. So I like hearing that. If someone says, I never want my mother to yell again, well, put in the chat if you've been successful at doing that because I want to talk to you. But it's just impossible. Okay. It's good. It'd be wonderful. I'd like to live in a home like that. Um, but what I'll take once I've heard the ideal is what would be good enough. And that's realistic. And I'm pointing that out because that's why I think this is really good. I care, you care about getting the kids' goal, but we got to make it realistic. And the only way you learn what is realistic is to first find out what their goal is. That they say, I want never to have whatever. You can say, well, okay, we can try. However, what would be okay? Because otherwise they're going to think therapy didn't work because it wasn't successful because I didn't get perfection. But you know what? Perfection I don't know. I won't say it's the enemy of the good, but it's a challenge in clinical work. So be realistic. And then the last thing, and not the least, is asking the kid, do you have any worries or concerns about being in treatment? They may say to you, well, my mother told me in the car, or my grandfather told me in the car, if I say anything about what he's doing, I'm going to get beaten. I'm going to get this. I'm going to get whatever. Okay. Or I'm really worried what's going to happen when I walk down the hall. So we have to really kind of learn this. And that's why I think you need closed door. Okay. So this is the reason we're here at this juncture. Okay. I want to just say a few more things about like examples of treatment strategies that I think fit any treatment. They just happen to be in the very, very beginning part of AFCBT, but they're things that probably all of you do. Um, and and for those of you who may not do all of them, maybe some of them seem sensible, I guess. Preparing the family for treatment. All of you who said you did do different treatments, safe care, PCIT, triple P, DBT, anything else that has a T. I mean, people are kind of coming in knowing what are those things. Those have lots of little pieces and phases and strategies and their own jargon and their own worksheets and their own, you got videotapes and other things for some, and you've got other things for others. It's important to kind of help them understand, even though you haven't yet said exactly what you're going to do, because you don't know, but help them take as much unknown and make it known. You know, say something about the structure and the content. Here's an example. We do individual work and we do some work with you and Susan together. Okay, we're going to teach a few skills, and guess what? We practice them in here. We're going to role play. Someone even mentioned role play, I think, earlier. I'm going to give you some feedback. Okay. I want them to know I'm not giving you feedback because you're bad at something. We do that for everybody. I'm not like singling you out. I just want them to know we will do this with every person. That's what helps everybody achieve their goal. I'm going to give you some home practice. That's not a sign that you're a bad case. That's a sign that you're moving through treatment and we want you to get the best out of it. But I also want them to know something else, which is, I want to try to maintain safety. I want you to be safe. Okay. And I'm going to maintain safety and be as respectful as possible. And that means I'm going to ask you, and I'm going to ask your kid, or if you're with a kid, okay, you're probably with both of them at this point. I'm going to ask both of you about these kinds of things because I need to know about safety. I need to know about what's going on in case I have to address those issues. Okay. I'll talk about what cash means in a minute, but this is what we do. Asking about the facilitators and barriers of treatment. You know what? If you wanted to come back, I would recommend you do this. Maybe you already do it. I know it's not easy to come back. I know it's challenging. I know there are obstacles. I know you worked hard to get here today. Can we talk about some of the things that are going to get in the way? Well, my job schedule, my this, my that. Yeah, we had a clinician, a colleague. She wasn't actually in our program, who worked with a trucker. I forget in what state. And she had to work around his schedule to do AFCBT on his laptop. And sure enough, she did. And it turned out great. She was so creative, but so flexible, you know. Um, Imagine if she hadn't figured that out though, and just said, "Hey, I'll talk to you next week." Well, the guy was in Montana. I forget where, but anyway, all these things, do it early. You know, what you can't overcome, what you can't address, think through and discuss with your team. Ask the parent to think through. Change how you're doing things. Oh, okay, we'll do telehealth. We'll do this. We'll do that. You know what I mean? Like the whole idea is to eliminate barriers to coming in. Okay, because no therapy, however good, is any good if they don't come back. The decisional balance you probably know, and I'll give you an example of one in a minute. You know, if someone isn't even sure about coming back, I've had my share. We to this day we still have people who say, I don't know, I might not want to do this. It sounds like a lot of work. By the way, I get it. It is a lot of work. If there was a pill or I don't know, a piece of clothing or something you could do, shoes you could put on and you get the skill, great. But I'm not aware of it. So it is important for us to help people who are ambivalent and recognize ambivalence is not a reason to say, get out of here, or I don't want you. And I know clinicians who have done that, you know, when people kind of say, I'm not so sure. Well, take that as that comes with the terrain, as I've said before, and then give them a summary of the whole thing. So what we talked about was this. I'm going to call here. I'm going to set this up here. I'm getting you bus tickets. I'm doing this. I'll have a snack. I'll bump up. You know, like that is what I'm saying we should do. This is why there's a lot of conversation in the early phase of treatment. I mentioned CASH. CASH stands for a check-in, okay, that includes an agenda, safety, and home practice. What does CASH really mean? It means every next session, we want you to kind of remind them that there's an agenda. You have content. You know, for some, I hope most, that's comforting. You know, one of the things I thought we would do today based on our treatment is X. Okay, talk about your family, talk about your feelings, talk about this, talk about that. Now, that also gives you a chance as you set your agenda to learn about their agenda. Oh, guess what? I just got kicked out of my house or I'm being evicted. Okay, well, you have to decide, is that something that's kind of worth talking about? Because people do have crises. We try to help figure out which are crises and which aren't. That sounds like a crisis to me, you know. And it actually just happened, actually, in one of our cases. And we did kind of have to stop and go, okay, let's think this through. And we're still thinking it through. But the first thing is agenda setting. Check in on the agenda and kind of get a frame for what you're going to likely cover. Then talk about safety. I'll talk about the strategy we use to learn about conflict and coercion next. And then if this was later, we would review any home practice. Okay, because we always assign, well, not always, but we most of the time assign a home practice assignment. Okay, so that's in a nutshell some of these beginning strategies. Now, can we predict basically what is going to be done over the course of therapy just based on our initial assessment in this first meeting or two? No. Like it's always fluid. Yes, we have content. Yes, we have a session guide. Yes, we have some targets. And that is not a bad treatment contract or a treatment map, an agenda for us to follow. But I mean, we're never that rigid that we say, sorry, I can't be bothered with this. You know, we have to always be open, but we try to help them understand what things are important for us to discuss because they truly are either crises or content relevant for AF, and what might be better done and more effectively managed by telling someone else that. And this is partly my comment about the agenda setting. There are going to be times when someone says, hey, can you call my my judge and tell her that I don't want to come back because I feel very much intimidated and put down. And you know what? There are times when we might discuss, well, what happened and other things. And other times we might say, well, you have a guardian ad litem, you have a lawyer, you have a this, you know? So it's not designed to deflect worthy, reasonable requests. It's meant to understand the ones that we should be dealing with, can be dealing with, and the ones that someone else probably can do better. And I have to say, the times I have reached out, or our clinicians have reached out for help on these other matters that draw upon someone else's expertise, they have gone far better than us kind of, winging it and saying, okay, I could try to call the judge. The judge says, who are you? Okay, I don't want that reaction. So anyway, it's just something to think about. It really is important for us to kind of understand. I know sometimes we say things like stay in our lane. I'm not sure exactly what the lane is. But it's not everything. It's not everything. So I just want to highlight. Okay. So now I want to say something about what we call the weekly safety check-in, which is a check-in to monitor conflict and safety concerns. And I have basically 2 slides on this. Okay. And then I hope I'll leave time for questions. So we can take a few of those if possible, and then I'll go on to the last section. You can read this. I'm not saying you have to say it this way. I have it in quotes because this is language we have proposed. But you should say, will say whatever it is that's comfortable for you. I just want you to understand the spirit of this. What is the spirit of this? Tell me about anything I need to know about where you guys could be possibly engaged in behaviors that could lead to safety concerns. Did you actually have a fight and someone got hurt? No. Okay. Did you have an argument? How did it end? Okay, good. You started using your skills. Or you didn't use your skills and this is what happened. I want to know this because this is often not something that these families often tell someone. If anything, they're often discouraged because they can get into trouble, as they'll say. And I get that. However, I have talked to them in the first session about the fact that I want to talk to them about these things, and then I will discuss with them the effects of telling me. And I have also talked to them about the fact that I'm a mandated reporter. So they know well in advance that I need to report certain things, but many things I don't need to report. And that is the line that's quite fine that we walk, right? You are mandated reporters just like I am. But many of the conflicts and arguments and fights and other upsetting things are not reportable. I would say less than 5% of the time from both our studies and our clinical work do we ever learn something that actually requires a report. Now, you might be thinking, well, that's a lot. And others might be thinking, well, that's not too much. But it is what it is. Like you may live in a setting that sees far more volatile, fragile families where the likelihood of reports are high. I can tell you in my current clinics, which are not only AFCBT, they're a whole set of things, but referred by child welfare or child probation. I bet we file a child line report once a week. So my point is, we know that. We know it may happen. When it is necessary, we do it, but we do it in certain ways. I won't go into how we do it. I'm sure you'll have a very nice procedure. But we need to learn about these things because they are opportunities for us to start better understanding what skills are they not using? What skills have I not taught? What skills do they need that aren't in AF to help minimize this? The other thing is, I want them to report problems. I want them to feel comfortable trusting me to address them. And then as you can see, we say, well, you had a conflict, you had a disagreement. What was it? Oh, okay. You weren't sure where you're going to have dinner. Oh, you weren't sure about a TV program. Oh, you weren't sure about whether you're going to go to the school, meeting, blah, 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 whatever. Sometimes they're bigger conflicts over discipline, over, spilling food on a rug, being disrespectful, fighting, pushing, smoking, having sex upstairs, whatever it is. I think we want to know about it. And if they had fighting or if it's getting to the point of escalation to aggression and safety threats, I think we want to know about that. And that's why you can see these questions. Did you use any physical discipline or punishment? And then what happened? what were her reactions? What were your reactions? What were their reactions? And what were police came, child protective services, got it. You know, it's not off, as I said, those things often don't happen. What you're going to learn is that they're eventually going to be using more skills and minimizing how much a conflict escalates. Do I think we can reduce even the experience of conflict in a lot of families? I don't think so. I mean, we all have conflict, we all have disagreements. I'm sure you do, I do. They just don't end up in, fights. Um, at least I can speak about my own home. I guess I can't talk about yours, but I'm making that aside. Okay, we do things that minimize the risk. And just as importantly, maximize the likelihood we get a successful response, resolution. We've dealt with our conflict. You know what movie we're going to see? You know what food we're going to eat? You know what this is that? Okay, you go to the school, I'll stay, whatever. That's what I think this is good for. And I know it's not an easy thing to do because we're going to learn about things that are upsetting to us too. But you know what? We get used to doing it from the very get-go. It's helpful. And if they're used to telling you, they will tell you about it and work with you on it. And that is the whole point. Okay, look to the right. I just wanted you to see the questions are the same types of questions. I just want you to see a little bit about what do you write? This is what the safety checklist includes. I don't list everything that could happen. I just want you to see these are common responses. This is property destruction, verbal abuse, physical punishment. But, and really importantly, there's positives in here. I thought about what I needed to do. I ended the conversation because I didn't want it to overheat. Okay. I walked away calmly. I talked about it. I told a friend. Okay. I used a skill in AFCBT. Okay. Again, and then you can see the open line. The blank is for anything else they did. Okay. I want to know what they did. You want to know what they did. And they will feel good, as you will, about doing positive things that help. I cannot tell you how many times I've heard clinicians do this. The caregiver has, with so much surprise, said, I can't believe this ever happened, but, my kid did this and I did this and it didn't escalate. Like, it's a revelation. It doesn't happen, well, it happens a reasonable amount, but not all the time. But this is what we're trying to do. We're trying to find alternatives to all the, verbally and physically coercive and aggressive behavior. And that's what this is designed. Okay. Safety planning. I know that you don't need to learn about safety planning. All I wanted you to know is that we include it. We include it. This is a simple one, and any safety plan has to be simple and practical. They have to be able to implement it. And what it needs are these pieces to me. There are far more elaborate ones. This is not my expertise. Those of you who work for child welfare, you did, or if you have those kinds of experiences, you know a lot more about this. But you got to at least know when this target hits, here's what you do before, or before it happens, here's how you prevent it. If it's happening, here's what you do during, and here's what you do after. And it's just designed to hopefully minimize, collateral damages, things getting to the point where someone's injured or hurt and killed. I mean, all of this is, I think of this as preventing that kind of catastrophic outcome. Okay. Not all of them are like that, but they can happen. Okay. So I just wanted you to know there are, if you do a weekly safety check-in, it would be awkward to say, hey, this sounds all good. See you tomorrow. I just want you to realize, yes, there are going to be times when you might need to set up a safety plan and monitor and manage it and maybe call. But I know you know how to do these, so it's not really unique to us. Let me say something about a few things related to our treatment. I just have a few more and then we'll take questions and then get into our last piece. I put this on here not because talking about experiences is so novel. What I wanted to highlight is we first talk about positive ones. Now you may be saying to yourself, well, why is that? Sure. makes sense. But you know, it's interesting. If you observe a lot of therapy, or you observe a lot of intakes, or first sessions or second sessions, and you look at a lot of manuals or session guides, a lot of times we're focusing on negatives, on the pathology. I had a friend who used to work in the abuse field, and they called it, we focus on the bruisology. You know, uh, we once saw a woman, and the first thing she did when she came to my office, she gave me x-rays, and they were of the fact that um, I think she or her husband, I'm forgetting if it was the husband, I think, shoved the tire iron through the kid's eye or near the kid's eye. And that was the first thing she did. She kind of led off telling me about herself and her family and her kid by kind of saying, here's his injury. And I said, okay, I'll get to that. We'll take a look. I want to know from you a little bit about your family. And I think this is really important. Everybody's expecting us to focus on the negatives. Oh my gosh, you did what? What kind of parent are you? Turn the table, you know, because yes, the stressors are important. You'll get to that. But you know what? It's just as important to know to give any positivity. Okay. So anyway, just something to highlight. And again, we go into this in more detail, but I just wanted to make the point that we can do a lot of good with simple things um, to set the stage for training them in individual skills. Someone had mentioned, I think, decision making as one of the things they do. I always appreciate hearing that. Maybe many of you do this. And this is borrowed from MI, as I mentioned earlier, the decisional balance. And, many of us do this. We do a decisional balance sheet. I'll show you one in a sec, where we discuss the helpful and maybe not so helpful or challenging things about being in therapy. This is a time when it's really good. Someone says, I'm not really sure I want to come back. Some therapists are upset by that and they feel put off. And they say, well, what do you mean? I've been doing this for 30 years. That's not the time to be defensive. They're not necessarily even talking about you. Okay. Um, how do you empower them to be their own decision maker? Because isn't that what therapy has to do? You're not going to be making decisions. They're not going to call you up in 6 months and say, hey, what do you think? Should we go on that vacation? At least I hope they're not. They shouldn't. Okay. We're supposed to teach them skills so they can be independent, self-sufficient. So I would do this from the get-go for anything that comes up where there's ambivalence about what to do or not do. And it's very easy for me to tell them what to do. And I can do that. I can say, oh, no, I can tell you, this is really good. Not a good idea. Better to say, yeah, I get it. You got lots of things going on. And I can appreciate it. So you know what? Let's go over this. Here are some of the pros and cons of coming back and some of the pros and cons of not coming back. It's probably for many clinicians like heresy, to actually think that not coming back even has some pros, but it does. Like this is just us having an honest conversation about all the influences over what they're going to do. Okay. And I do this routinely. Now, it might be something different later on in therapy. It could be using force, not using force. Okay. This is one of the beauties and the brilliance of the decisional balance in motivational interviewing and why we borrow it, because it's just so perfect here. It's not Dr. Kolko saying, you know, he he knows what he's doing, which many of my friends and colleagues would say, no, not really. But you know what? It's not me. Like, like I can't tell someone, you can't tell someone, it doesn't matter. Let them tell themselves by you working through this. Like, let's figure it out together. I don't even know what the answers are. But this is what we would do. And we would come up with what are the benefits of coming back. Well, I'm going to learn some things. I might get my kid back. Get see why, children and youth off my back, blah, blah, blah. Okay, are there any downsides? Oh, yeah, I work 2 jobs. I have to take 2 buses, blah, blah. There are lots of things. Every cell will probably have something in it. And then it's a matter of reviewing it. And you got to be kind of open to the idea that after looking at all this, they may say, it's not for me. That rarely happens, but it's happened. And when it has, we've said, you know what? Doors always open. Okay. Anyway, just giving some examples. And I mentioned this as well, and this, I think, the last slide before. We'll see if we can take questions. I always find it interesting because if you get cases like this, yes, you get a report, and yes, you might get even some evidence from a medical record, something about what happened. If you look at this graph, which we created as part of our topic 3, which is learning about the kids' feelings and their family experiences, and we ask about positive and negative or unpleasant, or sometimes we use the term not so nice. This is a graph created by the clinician with the child's health. I think it was an 11-year-old female. What you can see at 12 o'clock is why she was referred, the broken bone. So we knew she had her arm broken by her mother. We knew about none of the other things. And that's common. There's no assessment of all the things the kid is exposed to. You have to ask it, I think. And this is what the clinician did. And this is the outcome of a conversation about what are some of the positive things that was on a separate graph, and now what are some of the unpleasant things. And here they are. Okay. And I want to just ask you, you can think about this, but come up with an answer just for yourself. We don't have to really do it in the chat, maybe. But what do you notice? I'll tell you what I noticed in a minute, but think about it. What do you notice? Okay. You look at the total number of things, or the size, which indicates the extent to which those things happen. There's 2 observations, maybe, I'm wondering about. One is the broken bone is a tiny, tiny, tiny proportion of all the unpleasant experiences the kid has had. Remember, I made the comment, sometimes the trauma they're referred for is not the trauma that is the most upsetting. And by the way, I'm not broken bone's a terrible thing. Having your arm broken by your mother, a terrible thing when you're in an argument. Not discounting that. But it isn't everything here. It's why she was referred and why she went to medical care. I get it, bad. But it's not everything. Second observation. Did you notice how much of all these unpleasant experiences are verbal? It's about 3/4. It may even be more, but I think it was something like 3/4. Okay. So we never knew about pushing and poking and getting hit with objects. The parent was throwing stuff at the kid. So that was a revelation. But what was just as important, I mean, none of it is more important than the rest. It's all unfortunate and it's all important. But look at what this girl says about the amount of time, how often she's exposed to things. Look at this, yelling, threats, and insults 75% of the time. And look at yelling and swearing. Can you imagine that house? This is a third of the time there's yelling and swearing. I don't know. That's rough. This is all from the session, not from a report. Anyway, I'm just putting it on here to highlight why all these conversations are important. And I want to just give you a flavor for what AFCBT does. Okay. I'm at the end of this section. We have one last section. And I want to just find out from Diana. Diana, do you want to take a question or two now? Or do you want to move forward?
Since we just have one more section left, I think we can move forward and do the Q&A towards the end, if that's okay.
Okie doke. Very good. We will do that. Thank you, everybody, for your patience. I appreciate it. Okay, I'm going to give you a case. I want to just talk about a case for a little bit, and then I have a couple of finishing slides, and then we're done. This is JR. This is a case from a long time ago, actually treated by a woman in another state who was in an AFCBT training. This was her first training case. And I'll let you read it, but you can kind of see this is a kid with psychiatric disorders whose dad hurt him. Okay, broke his glasses, cut his face. He basically stepped on him and kicked him, and the brother watched it. Okay, But on top of that, look at the other contextual influences: divorce, domestic violence, emotional abuse. They had shared custody, right? And the mom has psychiatric disorders and lots of impairment. And look at the dad; he too has them, including they both have ADHD, but he also has anxiety and irritability. I mean, this is this is no case I would have wanted for my first training case. I'm not sure I would have wanted it now. Lots of cross-cutting, significant clinical problems in and of their own right, right? But we now know there was recent child physical abuse, and it was by the dad, and you see what it was. Okay, so I want to show you some assessment results on the APQ. The UCLA Reaction Index was the precursor to the child PTSD symptom scale, so it was a PTSD measure. And what you see is that the results that indicate what we learned at intake, which was that caregiver was saying low positive, low involvement, and high corporal punishment. So that was kind of helpful. It kind of gave us a little sense of they're not too involved together, and there's not much positivity, but if anything, when they are, there's a higher level of, harsh discipline. And that the kid had a partial diagnosis, was almost on the cutoff for PTSD. Okay. Okay, that's what she knew. Again, this is from a while ago, so some of the material and the assessments are a little old. I have a couple of slides I just want to show you about what they did, okay, from AFCDT. And I want you to just see who they did it with. Again, this is just to give you a flavor. They did the orientation with the mom. You see the mom is there. The dad didn't show. He was supposed to be there, but he didn't show. She set up a safety plan. They reviewed stressful life events. They did a decisional balance about coming back. The dad shows and says the reason he didn't come was because he was embarrassed and ashamed about what he did. And so the clinician does some psychoeducation and sets up an agreement, which we used to use to could he agree to using force less often? That's really what it is. It's just a verbal commitment. We don't really do it that way now. And she went over the weekly safety check-in. Then she saw the kid, did emotion regulation. He told the story, he did a narrative. This is early on, and this is what she did. It may not have been something we would have been doing now in AF at that early point, but she felt necessary to do it, and she did. And she discussed the incident, and she did try to address kind of a misconception, which is it was his fault. Okay. And then the dad was with his son, and they discussed the use of physical force. And again, they went into an apology session. They went into a bit of a clarification kind of quickly, where he created one. Why did she do that? Because he made one on his own, and he was ready. You know what? When people are ready, and she read the note, and it was good. If you're feeling it, she thought, okay, let's let it flow. Let's do it. And they did. And the kid was definitely comforted by this clarification. And he made a comment about, he's glad his dad is changing, and same with the dad. Then the mom came, okay, and she talked also about something like this. And mom said, you know what, I noticed my kid and my ex-husband are doing well. I forget what word she used, but former partner. Then they went into phase 2, okay? And at this point, she decided to do cognitive work first. You don't usually do it first. And then she went into motion reg. We usually do emotion regulation followed by cognitive work, and then behavioral work. So they did social skills, and then they did parenting. This is mostly, how we do it. And what was really interesting from the clinician was that the kid, when he was doing these role plays using social skills, said, gosh, this feels kind of weird, meaning this isn't really what I do. It's not really my repertoire. It's not really me. We kind of knew that. They hadn't encouraged him to be socially. I mean, what does it mean to be socially skillful? It means you care about others' feelings, about others' reactions to you. But when you're aggressive and coercive, you don't care. You take. You control. You don't worry about people's, reactions to you. You're not sensitized to that. And then on top of that, the mom and dad talked about their consequences, and they were kind of, I don't know why this was kind of a surprise, but they kind of realized, you know what? You do it this way, I do it the other way. It took a conversation like that with this clinician to do this. And then they talked a lot about trying to do the same kinds of discipline. Okay. You know, and then finally, the third phase, mostly similar to what we do now, not exact. It was communication with, the dad and JR. I think the mom had decided that she wanted the dad to be the focus, so I think she stopped coming. I don't remember exactly what she said, but anyway, so this is all family work with the dad and JR. Okay, they're working on communication, they're working on positive problem solving, meaning utilizing skills that are not aggressive. Okay. Um, and they came up with different, strategies and things that they would do together, because part of the problem was they didn't have a lot of opportunity and a lot of activities together where they could be reinforcing to one another. Okay. So that was what they did. Then they reviewed some of the problem solving scenarios they did at home. They reviewed at home. They came up with routines, which was great. And then there was a graduation exercise. And again, we just usually have them each say what they've learned so the other can hear it. And then we talk about what do you need for referral and listen for spontaneous comments. One of the spontaneous comments was the dad, who was originally against this, said, I learned a lot here. Now, I think, I don't know what words he used. And okay, maybe that's not the most emphatic, but sometimes that's an indication that someone learned a lot, like are different in just a few words. So anyway, I just want to say at least there was something that he seemed to spontaneously mention, which suggested he was different. And of course, it's good for your kid to not only hear it, but more importantly, to see it. And I think the kid did see it. JR did see it. So anyway, now, apropos of my comment about doing a discharge assessment, I want to show you some outcomes. Now, I never asked this clinician to actually do this. I mean, we mentioned it in the training, but she did. And I wanted to just show you, this is the original version of the APQ, which includes this corporal punishment subscale. So I have the father on the left and the kid on the right. And the kid also did the APQ, but also did the CPSS. Okay. And I just want you to see, first, if you look for the dad. So the dad says after treatment, that he's more positive, more involved, but less inconsistent and, less corporal punishment. It's, now, we still see some. And as I said, I don't know if we can get rid of every unwanted behavior in all of our families, but we work towards doing that. But he's at least going in the right direction on every scale. Okay. And, whether you want to say that's some improvement, a lot of improvement, who knows? But it was meaningful improvement to him. And look at the kid. The kid's got a similar profile filled out separately. More positive, more involved, less inconsistent, and less corporal. And then on the trauma scale, what's interesting is this kid goes from having a higher score, he cuts his level of traumatic symptoms in half. And it's interesting, we didn't do at the time anything to target trauma directly. Like there is no imaginal exposure in this earlier version of ASCBT. And I want to make a comment on, oh, by the way, before I make the comment, if you take a look at the very bottom, the mom spontaneously calls the therapist and says, I just want you to know that, I noticed better communication, their moods have improved and their behavior has improved. Okay. So we have a little independent and unsolicited feedback that things are a little bit better. But I want to make a comment about the CPS scores, about trauma symptoms. Why might there be an improvement, a significant improvement in trauma when we didn't target trauma directly? I think this may be the reason. By the way, this is all after the fact. This is my hunch. What is causing the kid trauma? The dad doing all these things. We've changed the dad. The dad is the trigger. The dad is the traumatic experience. And he's not just one experience. He has experience after experience after experience because he's in the house. Well, he's in at least one of the houses with this kid when the kid is there. Okay. I think that's the reason. Now, maybe there's other things. He's learned other skills and he can manage his emotions better. But that may be one of the ways by which this helps, which is you're living with people who are your triggers because they have engaged in aggressive, abusive behavior towards you, and you are making them less aggressive and punitive and abusive. And they're saying nicer things. So on top of that, you get a change for verbal and physical. Maybe that is kind of what impacts for these families, trauma experiences. Anyway, it's not the only thing, but that would be one explanation. Okay, a couple of comments on this case and one or two more slides, and then I'll turn it over to Diana. I just want to make a couple of comments. You know, I asked the clinician this, what do you think and why did this work this way? And again, it was all news to me because I only learned about it as she had done it. And though I gave her advice, I didn't really give her much advice. And I have to say, she really drove this case. So all the benefits really came from whatever she figured out she needed to do. And she just was very astute and, just very intuitive. But look at, this is what she said. She said, getting the dad engaged and the mom on board early turned out very helpful. She was worried that the dad wouldn't get engaged. And he decided to come because, he figured, hey, my wife, whatever she was, I guess a former partner was coming in. His mom was coming in, but the dad stayed away. And he kind of thought, well, maybe that's going to make me look bad, or gee, I could be doing this. And if she's going and seemingly okay, why not go? So I think that was really critical. Okay. And then getting them in the same session was important because JR was not wanting it. Like he was worried. What's going to happen? Maybe he thought the dad is going to, be upset at him for reporting on what happened or for being, I don't know, worried about being with him, anything. But they needed to do that because JR was avoiding him. And of course, that's what happens with PTS, right? You get avoidance. So they set up a schedule. But she also had concerns about his safety, which is why they did a lot of weekly safety check-ins. Like that is really something important. We never lose sight of the fact that he's living with this guy who stepped on his face and crushed his glasses, and hurt him and cut him in the face. So maybe it's a good thing that we're always mindful that could happen because it means we're asking questions and we're monitoring because we want to ensure safety as best we can. One of the challenges, and I made this comment earlier, was she said it was a challenge to coordinate among 6 providers. Don't forget that means she was the 7th. 7 providers, tough, and I can appreciate that. That was one of the first things that we started to think about. Could we do something about that when we worked on updates to AFCBT? And then finally, she said, I never really dealt with the dad's ADHD, but it would have made sense because you can appreciate how ADHD in him, especially if it led to impulsive behavior, could have led to somebody who steps on their kid's face, and hurts, breaks a bone in their back and other things. So anyway, this is the other reason why, yes, it's AF and yes, it's DBT and yes, it's PCIT and anything else. But you know what? We don't target everything. And sometimes you need to target other things. And we might actually get benefit. Like imagine that you might have been on a med. Maybe that would have helped even more. So anyway, something to think about. Okay, I'm going to switch gears and just say a little bit about training. And that is that we do have a training in AFCBT. If it is something you want, you can always go onto our website and look it up. I just wanted you to know what the general requirements are. I mean, this is what we look for if we're going to say that someone completed training. Okay. And the website has this. I just wanted you to have one slide with it. You sounds like many of you have other strategies and other treatments you use, and they may be working perfectly fine, and that's great. Maybe some of the strategies here supplement that, or maybe not. If you're interested in AF, you can always look it up and send an email or fill out a training form or whatever. But we have a training actually that just finished 2 days ago. So the next one I think is June. But anyway, sometimes we've had lots of people ask, and we sometimes get one earlier. But anyway, you're welcome to look it up. These are some of the things we ask you to do. They're mostly to ensure that you've gotten what we think is a reasonable experience, and we do our best to help you do that. Last thing I'll say about this in particular is, before I show you the website, is I want to come back to something which is agencies or organizations. I made a few comments about having policies and procedures. This is a change framework we use. It has other domains, but this is the one about the organization. And I just want you to have this, because I want you to realize, and you probably know this, and you probably already have this in place, but these are the things that a work group of folks around the country came up with when they were first starting to think about how do you help prepare organizations for AFCBT? Because we didn't know. And this is what they came up with. And they all seem pretty meaningful. They may not always be easy, but because if you're gonna welcome these families, these elements need to be in place. I think that was their thought. So I just want you to have it. And obviously, we try our best to help people do this, but some of it actually has to work within the system. Like, it has to be your own agency folks doing some of these things. Okay, this is our website, www.afcbt.org, and we try to update the website on occasion. And so we have different things here. This happens to be the one about our Spanish caregiver guide. But you're welcome to code AFCBT. You can actually contact us and ask about a training, or there's a training request. And as you can see on the right-hand side is a calendar. You can see how old this slide is, 2017. I didn't catch that. That's pretty funny. I actually did the one in Miami. But anyway, and it was a good trip. But anyway, you can take a look to see what actually is coming in this century. And then I've left you some references for some of our work. It's not many, but it's a little bit. And anyway, if you want other things, you can always make a request of CTAC. And then these are citations for the measures. And then finally, I want to just see if I have time for questions. I'd like to take a few. What I don't get to, I'm happy to answer if I can after, or maybe I'll send them back to Diana if that works, and and everybody can get an answer. But I just want to say thank you for this opportunity. I hope at least some of you are still awake, and I hope those of you are, that this has been helpful. I know if you're doing this work, you deserve a lot of accomplishments and praise, and appreciation is not easy. I hope this will make it a little easier. And with that, I'm going to turn it back to Diana. So thank everybody. Have a good rest of your day, and happy Valentine.
Thank you so much, Dr. Kolko. So so we do have a few minutes before we wrap up. So we're going to try to get through as many questions as possible. So again, we are still going live for the next 10 minutes or so. So please feel free to add in your questions. So I'm going to try to sort the questions through larger topics, a few things that came up. So in terms of families being honest and feeling comfortable enough, there was a couple of questions that came up around CPS or ACS. So this is a state organization, or it's run by state regulation. So it might be different depending on where folks are joining us from. But how do you help a family take a scale or fill out a scale and assessment as truthful as possible when there are fears or concerns about CPS or ACS?
Yeah, great question. What I would say is this: all of the scales we've picked, if they answered those questions accurately would not, in and of themselves, to my knowledge, and I have looked at them carefully, generate a report to child welfare. Even fighting a lot, that in and of itself is not reportable. So, I mean, we haven't picked things that by design trigger it. Now, follow-up conversations might, and this is part of a larger answer, but I'll give you the quick answer. In our first topic, we build in that we're mandated reporters and what that means before they ever tell us about what happened, because we want them to know, look, it's up to you what you tell me. If you tell me something that I believe I need to report based on my role, I will report it, though I will report it by talking to you first and figuring out which one of us does it. Like, we have a whole protocol for doing that. I want everybody to be informed by that from the get-go. But really, nothing in particular in the assessment and nothing in particular in the manual generates, in and of itself, a reportable action. It's only if someone says, we had a fight, and then we say, well, what happened? Well, I picked up, a piece of metal and I hit him. Or we had a woman once who threw a knife at a kid and just grazed his ear. She meant to kill him, but she wasn't a good shot, and that's fortunate. And we told her, you know what? Our child welfare system may not think that that is reportable because it's not serious physical injury, which is how at the time it was defined. But we think, for your son's safety and protection, that we need to report it. So there are times when we do, and when we do, we do. But we do it, I think, with some other guardrails and preparation, and we get their involvement. But almost all I can't think of any one question that leads to a required, oh, you said this, this is what we have to do now. And I, by the way, we've been doing this a long time and we haven't. But there are times when people just tell us things. And look, here's the other thing. What would you rather have? They don't tell you, and there's no report, and there's no help, and something happens to a kid, or they tell you, and we let the system do what it does, even though we sometimes, may have difficulty with how the system sometimes operates, and other times we might welcome it. I will say this. We very rarely lose a family to AF treatment when we have filed. It happens, but not that often.
Great. Thank you so much. Yeah, I'm hearing a couple of things along the lines of, obviously the regulations at the state level for each Child Protective Service or ACS, clinical decision making, but also that transparency piece. So there was a question about, do you discuss with the family if you're making a CPS or an ACS report? And what I heard you say is right off the bat, you do inform families from the beginning that you are a mandated reporter. So thank you for that. Let me move to questions, I guess, that maybe have to deal around with the assessments. So one of the questions that came in as you were introducing some of the recommended assessment measures is the ACEs questionnaire, the Adverse Childhood Experiences questionnaire as an assessment. Would you recommend that? What are your thoughts about including that in an assessment phase?
Yeah, and I didn't actually speak to it. So, well, here's my thought. We have a limited amount of time to learn what we need to learn. If you say, I need to know that, then do it. Why don't I? Well, quick answer is what we use tells us enough of the things we feel we need to know. Secondly, I sometimes worry about the value, the impact, and the use of a questionnaire that gets a whole list of those, because then what do? Are you going to work on minimizing those things? Are you going to target those? Are you going to treat those? Like sometimes it's just so much information about so many different adverse experiences. I mean, what can, if you have the opportunity to address them, great. If you have the opportunity, if it's important because you have a lot of those adverse experiences, like a caregiver who's incarcerated, things like that, mental illness, they're important. Um, but yeah, I guess we've just put more of our faith and our focus on the clinical targets we can change, and then we try to learn about, not through a form um, like that. We have another form that's like it. I didn't mention it. It's not an assessment. Well, it's not an assessment at intake and discharge. If you look at AFCBT, you'll see in topic 2, we have a stressful life events checklist. And we do that as part of our session, not as an assessment at intake. Why? Because it's our way of saying, tell me about yourself. What do I need to know? How can I be more empathic to you? So, so that's the one thing we do where they actually can check a list of a lot of things. It isn't an ACEs checklist, but it is pretty similar in many respects.
Great. So, Dr. Kolko, I will say that we do have a good number of other questions that I think would just obviously require much more time, and I am mindful of time. So, I know you offered to answer some of these questions, so I'm wondering if we can actually take you up on that.
Sure.
Uh, Great. And if that is the case, just a reminder for folks, our coordinator, Vanessa, thank you so much. Just put a link in the chat box for a survey for you to fill out. For folks, as a reminder, and Dr. Kolko, if you could just go to the next slide, great, thank you. We do have some upcoming events next week, understanding and addressing microaggressions in children's mental health services. And on that final slide, we do have a reminder for you folks to visit our website. The slides, the recordings will be up on our webpage within the next 2 to 3 business days. To those of you who are eligible for CEs, you will also be receiving a detailed email within the next 2 to 3 business days. It will take us a little bit longer to maybe get the Q&A posted. So Dr. Kolko and I would work on that, but we will hopefully get that to you within the next 2 weeks maximum, just, to kind of refresh and answer your concerns and whatnot. So again, please feel free to visit our website in 2 to 3 business days to see the recording, and about another 2 weeks just to see the responses to the Q&A, just to allow sufficient time for that. So again, on behalf of CTAC, I want to say thank you all of you for joining us. Thank you to you, Dr. David Kolko, for such an informative presentation. So again, thank you all so much, and have a great weekend and a great rest of your day.
Thank you. Bye, everyone.